Hello and welcome to this EMJ GOLD Catalyst of Pharma interview. I'm Dr Julie-Ann Lough here on behalf of EMJ GOLD, coming to you from ESMO 2025 in Berlin. I'm joined today by Dr Vikram Chand, Vice President and Global Franchise Head at AstraZeneca. Dr Chand brings over 15 years of experience in the biopharmaceutical industry, having worked across every stage of a medicine's development, from early stage research through to late phase clinical trials and onto global registration. In his current role, he leads the clinical strategy for one of AstraZeneca's antibody drug conjugate assets across multiple solid tumours. Beyond his day-to-day, though, he is guided by the belief that no patient population is too small and no cancer too difficult to treat. As a leader, his passion lies in defining a clear, patient-centric vision, mapping an efficient path to achieve it, and enabling his team to make that vision a reality. Today, we're going to talk about his journey from medicine into pharma and the perspectives he brings to oncology, how he thinks patient inequalities should be tackled, and the one thing he would change about healthcare. Vikram, welcome.
Thank you.
So you initially started off life as a doctor. And I think it's always interesting when people change career path or, deviate from what might have been the traditional route. So what inspired you to transition from medicine into the pharmaceutical industry? And how have your clinical experiences shaped your leadership approach?
So first of all, Julianne, thank you for having me. As you know, I was born and raised in India, and my early years were really formative by seeing my grandfather, who was a small town practicing physician. He had an immense following in the community, but unfortunately, when I was 11, he passed away from lung cancer. So there was a deep embodiment in my sort of growing up years that I needed to become a physician and help towards finding cure. And lung cancer sort of became one of those tumor types which sort of was entrenched from the family experiences that I had. And that took me, through a journey where I moved to the United States to train as an oncologist and a haematologist, and then subsequently, into pharma.
It's interesting there you talk about your grandfather and him passing away from lung cancer, but you've also quite openly spoken in the past about a personal connection to triple-negative breast cancer. How has that experience then shaped the perspective that you bring to your work in oncology?
So, we are living in an age today that as you treat patients, there comes a day when cancer comes knocking at your own door as well. So all the empathy and the time that you spend with your patients, it can become a very different experience when you see it personally, especially when you're an oncologist. So 3 years ago, my sister-in-law got diagnosed with early stage breast cancer, and I had to experience and see what she had to go through with chemotherapy and help her guide through the therapy. The more important thing was it was also at a time when we were actually designing our clinical trials, especially in triple-negative breast cancer, and I could relate that how we could design a clinical trial that actually could reduce the burden that she's going through. I'm very fortunate that she's doing very well in the 3 years that have been there. But it emphasizes the point that clinical trial participation and patients actually getting the right care in that environment and us changing the boundaries of medicine by pursuing these new therapies is the way to go.
So what changes did you incorporate? Curious from that point of view. You've already designed this clinical trial. Your sister-in-law is going through this issue. Did you go back to the team then and say, guys, I think we could change this a little bit. Maybe we could add in this or that. I'm just curious as to about what the changes were.
So some of the activities that we were seeing with the drug, one of the drugs that I'm actually working on, an ADC, has shown really good promising activity. And this year at ESMO, we actually presented very strong pivotal data in first-line metastatic setting. But the key was to actually bring that therapy, which is giving a lot of good outcomes in metastatic setting, to an earlier stage setting. To be able to replace chemotherapy, the side effects that people go through, and convert that to a different therapy and give, completely change their outcome. And hopefully by giving that drug early on, drive better cure rates. So I think that was the key thing that actually pushed me more, that there was a reason that we actually had to bring that treatment option and clinical trial forward So that's how it, we got the motivation.
Yeah, I think that's a really important point, isn't it? Like, it's great to, to come up with treatments that might treat cancer, but if they're impacting quality of life or the side effects are too much for people, that can obviously impact on compliance rates and that sort of thing. So it was great to bring that personal sort of perspective to it of like, yeah, we need to try and get stuff access to earlier people that'll prevent, side effects or long-term metastasis. And you've also spoken as well how you're quite passionate about health inequalities, and it's clear that that's a passion of yours. When it comes to addressing inequalities in triple-negative breast cancer and beyond, I suppose, which area is that? Is that research? Is that policy? Is that advancements? Do you think is going to be key to sorting out those inequalities, and why?
Yeah. So if you look back just about 20 years ago, we did not have, division of breast cancer as we know of today. Only in the late 90s that HER2 became a prominent target that we could actually give drugs towards. And before that was hormone receptor positive or estrogen receptor positive or progesterone receptor positive cancers. And what landed up happening since the last 20 years or so, there is a sizable patient population, even though 15%, these patients have none of those markers. And all these 25 years, all they've had to deal with is chemotherapy. Okay? And the outcomes have been relatively poor. 12 months to 18 months is maximum that their median survival would be. So I think that population really is the one that we actually aim to actually bring treatment options to. And today, at this ESMO, as we presented data, we presented that our ADC was able to actually beat chemotherapy and prolong survival for these patients. So I think these are the kind of things where we need to progress further. And again, bringing these treatment options from metastatic setting and then moving it on to the earlier line setting to be able to make more patients getting cured so they don't advance to a metastatic setting. That's the initial part that we need to work on.
Yeah, it is that, isn't it? It's that preventing metastasis, but also exactly ensuring that people have prolonged survival, ensuring that in that survival time they have a good quality of life, especially for maybe younger women who are mothers and have small children. They want to be around as long as possible.
Absolutely.
You briefly mentioned then the presentation that you listened to this morning at ESMO and that you were launching some results there. As I mentioned to the viewers and the listeners, we are recording this at ESMO 2025. Is there something particular that you've heard over the course of this Congress that you're going to take home with you that you think is very exciting in the field, very thought-provoking?
Yeah. So I actually gravitate to two of the ADCs that we are developing. It emphasizes the two key needs. One I just talked about in metastatic triple-negative breast cancer, but simultaneously, one of the other ADCs, which was a HER2-targeted ADC, was able to actually show dramatic results in early-stage breast cancer. If patients actually replaced their chemotherapy with an ADC upfront, they got to much more higher pathological complete response, meaning their tumors at surgery were not found after they had received ADC in combination of chemotherapy. And then those who had not received an ADC upfront, after they had their tumors resected and they had high-risk disease, they could receive the ADC and their outcomes were much better. So combining this gives me that encouragement that for the triple-negative patients, we can actually now hopefully get that outcome from metastatic setting to an earlier stage setting. And this is one of the most aggressive diseases that thus far had no targeted therapy available to them. And it almost gives me goosebumps to say that these women now have much better hope and much better outcome to look forward to.
I think that's really interesting. Actually, it's quite an interesting result, especially now with like routine mammograms. People are finding cancers earlier. So if we can get a treatment for people when an earlier cancer is detected, as you were saying, that tumours aren't being seen by the time you get to surgery. It's, might save breast tissue. It might then obviously prolong women's lives, improve quality of life. That is very, very exciting. I'm going to hand you a crystal ball now. We're going to look 75 years into the future. What are the emerging concepts or technologies that you are seeing coming down the track that you think could transform the landscape for our understanding of how we understand and treat cancer?
So look back the last 75 years. 1940s or 50s is when the rudimentary chemotherapy started to come through. And since then, the advancement took a longer time. But in the last 25 years, you've started to see exponential growth in us having the ability to find targets and reduce toxicity, improve outcomes for patients in many, many different tumor types. I think this is just the beginning. From here on, I see with advancements that we have with AI that is going to play a significant role in healthcare, improving access for patients, early detection, and also getting digital ways of figuring out what the targets are to personalize treatment and improve outcomes. That's the exponential thing that I'm going to see. And 75 is a long time. I think you will start to see these effects in the next 5 to 10 years to grow substantially, and the patient's outcomes are going to get much better.
Yeah, it's very interesting, isn't it? That idea of we're moving closer and closer to personalised medicine. What's the actual biochemistry going on with somebody's tumour that we can target specifically? And that's really going to advance treatments. This interview series is called Catalysts of Pharma, and we know that catalysts drive change. So if you could change anything about healthcare, what would you change and why?
I think I go back and entrench myself as the practicing years that I had. The training that I had was grounded in evidence-based medicine, and evidence is generated by clinical research and clinical trial participation. If there is one thing I could do, I would strongly encourage that clinical trial participation for patients who have cancers is going to change their outcomes much better, and we learn a lot more much quicker. And if there is one thing I can change is improve the patient participation in clinical trials and make more clinical trials available to patients to participate.
That's a really good place to end, I think. And it's actually, I think, really highlighted back to the beginning, when you were talking about your sister-in-law and how it drove your decisions around designing clinical trials to think about how is our clinical trial impacting on the patient. And by thinking from the patient perspective when designing clinical trials, you're probably going to improve uptake and participation as well. I think it's really very great that we've been able to discuss how we might be getting potentially more personalised treatment, particularly for those more complex cancers, and getting treatment in earlier to patients to prevent that metastasis. That's, I think, it gives hope to a lot of people.
Absolutely.
I think that ends our discussion for today. It's been really interesting, Dr. Chand. It's been an absolute pleasure to talk with you. And to our viewers, don't forget to subscribe to the EMJ GOLD newsletter for more expert interviews and insights just like this one. Do follow us on social media and to stay connected and up to date on everything. But thank you so much for joining me. And Dr. Chand, thanks very much for being here. Until next time, stay safe, stay well, and most importantly, stay curious. Goodbye for now.